So
Yes.
I'm Michael Freeman. I'm the Herbert Christopher Fellow in Neurotology here at Vanderbilt, and I'm going to briefly tell you about a transeustachian endoscope that I've helped develop for middle ear examination. Traditional access to the middle ear is done through the ear canal or through the mastoid. The idea of going through the eustachian tube, many people have thought of it, but the traditional obstacles to that have been access. The eustachian tube is extremely long and narrow and tortuous. And having a device that can traverse the eustachian tube has been a technological limitation in years past. The other problem is that if you were going to have a diagnostic technology, you have to have sufficient optical quality. Carrying enough light through an endoscope that can make it through a tube that narrow, and then referring back sufficient detail in your imaging is very difficult. A fiber endoscope, like a traditional endoscope used for silentoscopy of the salivary glands, would give you 3,000 to 6,000 pixels for an endoscope that's less than 2 millimeters. If you compare that to a distal camera endoscope like the ones we traditionally use now in the clinic setting, those have multi-megapixel resolution, which is much better for diagnostic purposes. Being able to combine distal camera endoscopes with a small endoscope is something that really only recently has become even technologically feasible. In terms of innovation strategy, I, as a resident, met Josh Gafford, a postdoc in the Vice Vanderbilt Institute for Surgery and Engineering, and his specialty was multi-nested endoscopes that give multi-directional steerability while minimizing diameter. So the idea is that traditional endoscopes incorporate a pole wire, which takes up space within the endoscope. And if you're going to have a pole wire, you have to have two of them to steer two directions. This technology branched out into a private company, Endothea, that's based in Midtown, which applied for and obtained a SBIR grant. The idea behind it is combining that in-house proprietary technology with commercially available micro camera technology. This is our original endoscope. You can see a photo of it on the right. It's very small. It's 1.6 millimeters outer diameter and provides 1 megapixel resolution, but only was able to steer one direction and flex only up to 90 degrees. Our current device, seen here, can go through the nose of a whole head, advance a catheter into the cartilaginous eustachian tube here, and then steer once placed within the middle ear. This portion allows for bidirectional steering and 360 degrees of rotation for 4 degrees of freedom. Trying to go to my next slide here. There we go. Here's some images from the endoscope in cadaveric specimens. You can see this is a right ear, tympanic membrane. The 3 bones of hearing are visible here, the stapedial tendon, and then some of the suspensory ligaments of the ossicles. You can see this is the whole middle ear space. This is flexing the camera up to look at the roof of the middle ear. This is the tegmen, which is the bone between the brain and the ear. And then if you look down, you can see the floor of the middle ear. The jugular vein or the jugular bulb is right down here. This is a second specimen. You can see there's a lot of debris in this particular cadaver, but there's still a lot of clarity in the images. You can imagine that if this patient had a disease of the middle ear like cholesteatoma, you would be able to appreciate it. These are suspensory ligaments of the ossicles. This is the floor of the middle ear. This is the tympanic annulus here. And then this is a close-up. You can see the stirrup shape of the stapes and the attachment of the incus and the stapes bones. This is the third specimen. Like the second one, it has some debris just artifactually from preservation of the cadaver. But you can see a lot of clarity in the anatomy that we're able to see. A close-up of the ossicular chain, the malleus, incus with eye, and stapes here. In terms of future directions, one of the problems that we've come across in our cadaveric testing is the eustachian tube contains mucus. We've been able to bypass that using traditional balloon dilation catheter kits to make the eustachian tube wider, but ideally we would have a lens clearance mechanism. The incorporation of the nested tube technology allows us to reduce the reduce the size of the device, but also could incorporate something similar to an endoscrub technology, a laser fiber, or a suction. We also would like to be able to determine candidacy before we do in vivo testing at any point, and that would be CT or similar technology could be used for that. And then longer term, understanding the safety profile of a technology like this, because while people have cannulated plenty of eustachian tubes in patients all across the country for decades, this type of approach has never really been done before. And then longer term, commercialization is really contingent on engagement with existing companies that could help build out this technology. Here's some references, and thank you guys for your time.
Great. Thank you very much, Dr. Freeman, for that great presentation. I'd like to start by asking you what you think. You're doing cadaver studies right now. What do you think your biggest challenge will be in moving to studying this in humans?
Well, I think that there are two big challenges. One, as I alluded to, is having it consistently work in light of the fact that there's mucus in the eustachian tube. We're not having it work every time in every cadaver specimen right now. And I think that the hurdle before you could implement this in people is having it work nearly every time in nearly every specimen. So that technical hurdle is probably our biggest issue. And then, having clinicians buy into the idea of cannulating eustachian tube for diagnostic purposes. Like anything, there are early adopters and late adopters, and I'd like to think that most surgeons trend toward the former, but nobody wants to put patients at unnecessary risk. And I think that doing the necessary cadaver research to demonstrate that there isn't damage done to any of the tissues, I think would be the hurdle to being able to implement this in humans. There would probably be a stage at which this would need to be built out and modified slightly for an animal study, which probably wouldn't be hard, considering that there are plenty of animals that have comparable anatomy. But I think that overall, it's a technology that surgeons would embrace once safety profiles have been fleshed out.
Yeah, and so on that topic, what have you done to understand the market so far around how much would this be embraced by surgeons out there?
Yeah, so the original idea behind it was detecting cholesteatoma, which is a skin cyst that grows within the middle ear. And it's been shown that when you do cholesteatoma surgery, a lot of surgeons do what's called a second look surgery, where they'll go back in and do a second surgery just for diagnostic purposes. And cholesteatoma is only discovered in about 37% of those cases, meaning that 2/3 of the cases done for that purpose are unnecessary. The idea behind this is this could obviate those unnecessary surgeries. There are other side uses, but there are many, many, many thousand of those surgeries done across the country every year, and this could take the place of those surgeries.
Okay. And what about from a regulatory perspective? Have you mapped out what that would look like in order to be able to start using this in humans?
Yeah, the regulatory hurdles for a technology like this would follow a similar pathway to the eustachian tube balloon catheter pathway. It's the same anatomic region. Similarly, it's a technology that has not been done before. About a decade ago, Johnson & Johnson started doing transeustachia balloon dilations, and then Stryker got into the game a couple years ago as well. Following their pathway would probably be the most efficient way to bring this to market.
Yeah. And your company is Endothea. So does Endothea own the technology or license the technology now from the university, or?
I think Endothea owns the technology, at least the proprietary portion of it they do.
Yeah. What are your thoughts on future relationships with larger industry players, like you just mentioned, like Stryker, et cetera? Is that something that you guys are considering as part of the journey?
Yeah, we've had talks with a couple companies at this point.
Okay, great. Thanks so much, Dr. Freeman.
You're welcome.